discusses about the application of GRADE in dental research, how GRADE enhances reporting of evidence quality and recommendation strength. I am Shaji Jacob Pulikotal from Riga Stradinia Universitate. GRADE is an acronym for Grading of Recommendations, Assessment, Development and Evaluation. It is a standardized system and a method to assess the quality of evidence, strength of recommendations, especially in healthcare. It is widely adopted in clinical guidelines, including dentistry. It was developed by a widely representative group of international guideline developers and can be accessed by individual researchers and reviewers through their GradePro website. GRADE ensures transparency, reproducibility, and robustness in developing clinical guidelines. It helps clinicians make informed decisions by balancing the desirable and undesirable effects of interventions. A number of criteria need to be used when moving from evidence to recommendations. Judgments about the confidence in estimates or quality of evidence to judgments about the strength of recommendations are important to be made based on the context and purpose. High confidence in effect estimates does not necessarily imply strong recommendations, and strong recommendations can result from low or even very low confidence in effect estimates. This separation of assessment is what makes grade assessments very important when evidence is translated into recommendations. Let's understand the key components of the grade approach and deal each one separately. First, formulating clinical questions. Second, rating the importance of outcomes. Third, summarizing evidence. Fourth, assessing the quality of evidence. And 5, developing recommendations. Formulating clinical questions. A guideline panel should define the scope of the guideline and the planned recommendations. Each recommendation should answer a focused and sensible healthcare question that can lead to an action. The clinical questions are framed using the PICO framework: patient, the patients or population to whom the recommendations are meant to apply; interventions, the therapeutic, diagnostic or other intervention under investigation; comparison, the alternative intervention or intervention in the control group; and outcome, the outcomes of interest. Example: should manual toothbrushes versus power toothbrushes be used for dental health? Rating the importance of outcomes. A clinical question might address multiple outcomes. The guidelines panel should consider all outcomes that is relevant to the clinical question and not the outcomes for which evidence is available. If any outcome does not have evidence or studies, it should be acknowledged. GRADE specifies 3 categories of outcomes according to their importance for decision making: critical, important but not critical, and of limited importance. Critical and important outcomes will bear on guideline recommendations. The third will in most situations not. Ranking outcomes by the relative importance can help to focus attention on these outcomes that are considered most important and help to resolve or clarify disagreements. The importance of outcomes is likely to vary within and across cultures or when considered from the perspective of the target population, that is, patients or the public. Summarizing evidence. A guidance panel should base its recommendation on the best available body of evidence related to the healthcare question. GRADE recommends that evidence from systematic reviews should form the basis for making healthcare recommendations. 2 approaches with iterations for evidence tables are available, which serve different purposes and are intended for different audience. The first one is a grade evidence profile, and the second one, summary of findings table, which is either one of which is used. The guideline development tool available in GradePro website facilitates the production of both evidence profiles and summary of findings or SOF tables. This is a evidence profile table from a systematic review of association between tooth agenesis and cancer. It includes a list of the outcomes, the number of studies and study designs, judgment about each of the quality of evidence like the risk of bias, inconsistency, indirectness, imprecision, and other considerations, including publication bias and factors that increase the quality of evidence. The risk or the impact of the effect is also described, how much certainty is given, and finally, the classification of importance of each outcome as critical, important, or not important. Footnotes, if needed, to provide explanation about the information in the table are given. Similarly, the standard format for the SOF summary of findings table includes a list of the outcomes, risk or effect depending on the variables types, the number of participants and the number of studies and the designs, rating of the overall quality of evidence for each outcome, which may vary by outcome, and footnotes or explanation. Assessing quality of evidence. The quality of evidence reflects the extent to which our confidence in an estimate of the effect is adequate to support a particular recommendation. The quality of evidence is at 4 levels. High, when we are confident that the true effect is close to the estimated effect or risk, while very low indicates that we have very little confidence and the true effect is different from the estimated effect. The next is factors can decrease the quality. Factors that downgrade quality or the evidence are study limitations or risk of bias, for example, in RCTs, lack of allocation concealment, while in observational study, when the outcomes are flawed, inconsistency as shown by heterogeneity with no proper explanation, when no direct evidence is available, for example, using animal study results to give recommendations for human ailments, imprecision due to inadequate sample size leading to a wide confidence interval of the effect estimates, and presence of significant publication bias. How about the factors that increase quality? Factors that upgrade the quality of evidence is when the effect size is large, there is a dose response gradient seen, and when confounders are expected to reduce the magnitude of difference. Developing recommendations. The strength of a recommendation reflects the extent to which a guidance panel is confident that the desirable effects of an intervention outweigh the undesirable effects, or vice versa, across the range of patients for whom the recommendations is intended. Consider the following when making recommendations: balance of benefits and harms, quality of evidence, patient preferences, and resource implications in clinical practice. A strong recommendation is one for which guidance panel is confident that the desirable effects of an intervention outweigh its undesirable effects. Strong recommendation for an intervention, or that the undesirable effects of an intervention outweigh its desirable effects. Strong recommendation against an intervention. A strong recommendation implies that most or all individuals will be best served by the recommended course of action. How about weak recommendations? They are described using the following terms: conditional, depending on patient values, resources available or setting; discretionary, based on opinion of the patient or practitioner; and qualified by an explanation regarding the issues which would lead to different decisions. Challenges. One of the most important Challenges is the limited high quality of evidence available. Further, strategies to overcome include use of systematic reviews that reduce the bias of reviewers and provides high quality evidence leading to proper recommendations. Also, use of expert opinion should be used judiciously. Conclusion. The GRADE approach improves the quality and transparency of clinical guidelines. Its adoption in dental research ensures evidence-based, patient-centered recommendations. Thank you. These are my references. Bye.